for me it's a unique opportunity to be in a very competitive scientific surroundings, and in the same time really work in the field, being where it's happening, instead of doing international health in Amsterdam when everything is really happening a few thousand kilometers away from you. So I think this is the unique thing about APHRC that attracts scientists like me, and attracts organizations from the West. Well, the scale-up model is actually a service care delivery package. So it's a bit difficult word, but what it means, we look at the whole neighborhood, and we look at how can we reduce the risk of cardiovascular disease for the whole neighborhood. So we go to Korogocho, where 35,000 people live, and we think, how can we reduce the risk of getting a cardiovascular disease? And that starts, most of the times, that people don't know actually what hypertension is. They don't know if they have hypertension. They have never been screened. So you have to take a patient without knowing that he is hypertensive all the way to the moment that he's taking medication. So we have developed some key steps, like creating awareness, having access to treatment, follow up with treatment, and to really stay that people with treatment. So we focus on different aspects in this whole service care delivery. So what we do is we start with screening. We start with a door-to-door screening. So we will target people above 35 because age is also an important risk factor. And more than 70% of the people with high risk factors are in the group above 35. So I think that's also a key aspect of our program, that it should be cost effective. So money is a very essential element. The idea of this study is that it should be sustainable, and after 3 years, when the funding stops, the model can continue. And ideally it should be even scalable. So this model, we are now trying to prove this in Korogocho. And when it works, we would like to use it also in other slums of Nairobi, and potentially in sub-Saharan Africa. This model contains screening, household visits, so then we will knock on the door and ask if people about 35 years old would like to measure their blood pressure. People will know, hopefully, about the screening by organizing barazas, and we will also empower community health workers, and they will visit religious services, and we will also develop radio jingles. So that way the people won't be surprised when this community health worker will knock on their door and say, hopefully you've heard of the program, and we would like to measure your blood pressure. Then, besides measuring the blood pressure, they will also explain about cardiovascular diseases. What are the risk factors? What can they do? And people with a high blood pressure, they will be referred to a clinic. We know from earlier studies it's sometimes very difficult to get people from being screened to get them into the clinic, because sometimes people are still not convinced. So what we try to do is to also create incentives for patients and also community health worker to really follow up that this patient is going to the clinic to seek treatment. Then the community health worker will get a small amount of money. The scale-up is actually a 3-year project, where in the first year we really develop this. So we have developed this based on earlier research done by APHRC on CVD, based on literature research on reading and learning from best practices from other places in the world, in China, India, also from the West. This model has a really strong potential to be a successful model of prevention of cardiovascular disease.